Egunon guztioi eta eskerrik asko etortzeagatik, ekitaldi honetara. Estamos encantados y encantadas de recibir a las compañeras y compañeros del proyecto IMPROVA y de empezar este seminario que ahora voy a pasar a presentar en inglés porque tenemos la mitad de la audiencia internacional y bueno, pues para que sea accesible para todos y todas. So, good morning, welcome everyone. I was just saying we have an international audience in person and online. I am Rocío García Carrión, Nickerbus professor at the University of Deusto, here at the Faculty of Education and Sport, and I'm delighted to welcome to you all to this event, Boosting Mental Health in Children and Adolescents, Promotion, Prevention and Intervention. We have signed more than 150 people sign up for this event. We are only a part of us here because the rest are online. Welcome to you all from many different countries in Europe and Latin America, from different times and places. Welcome to this event. It's a unique opportunity for us to do this event as part of the IMPROVA project. IMPROVA is a Horizon Europe funded project for 4 years, coordinated by the Fundació Sant Joan de Déu in Barcelona. We have here our coordinators, and we have the privilege from the University of Deusto to be partners of this consortium. For those who are not familiar with this is a large-scale project that Rodrigo will tell us a little bit more about that later. And we are halfway through the process. We are in the 2nd year, and we have done so many things with this purpose and with this dream. To improve adolescents' well-being and mental health, which, as you know, is a crucial priority for our society, for our public health. So we are truly committed that research can give so much to the society. And that's why we are here today. I am not taking that longer because we have that unique opportunity to have 2 wonderful speakers. First, I will introduce Rodrigo for the first intervention. And then our second keynote, which is Professor Pim, Cuijpers, sorry, for the second part of the session. So the program, as you received it yesterday, as a reminder, we will have a keynote from Rodrigo. I will introduce in a minute, and then question and answers for the audience. I welcome all those you online to put your questions on the chat, and we will pass into our speakers as well. So with that, thank you to you all for being here today, early this morning. We are going to start the program with the presentation of an e-health intervention to promote mental health, the IMPROVA platform. We have the great opportunity to have here Rodrigo Lima. He's a researcher at Parc Sanitari Sant Joan de Déu in Spain, a member of the Center of Biomedical Network Research on Mental Health, CIBERSAM. He serves as the scientific coordinator for the IMPROVA and is the principal investigator for the Pro Schools, another EU-funded project by the Health Programme, which also aims to promote health and well-being among youth through an e-health intervention program. So thank you very much for being here today with us, Rodrigo. The floor is yours.
Hello. Wonderful, thank you. So it's so nice to be here. It's lovely, it's a great opportunity. I would like to thank our hosts, University of Deusto, and especially Sarah and Rocio for this amazing event and organization. It's nice to see the room full, a lot of people joining online. This is an excellent event. I would like to thank you all. Also would like to thank our partners from the IMPROVA project, who are the ones behind all of the slides that I'm going to present here. Everything that I'm going to present here, it's a result all of the collaborative work that we are working together for these last 2 years. Also would like to thank Pim for the generosity to be here with us and give his talks with us. So I'm here to present just a portion of the project, focusing more specifically on 3 objectives, like improving the part of the project in which we are trying to improve adolescent mental health and well-being, early detect mental health problems, and prevent common mental health problems. As Rocio anticipated, this is a EU-funded project We have 13 institutions from 7 countries in Europe represented here. And this project started with the mental health crisis in the youth population. As you know, half of the mental health problems, they will have the onset during adolescence. And once this person has the onset of any mental health problems, the likelihood of having a second recurrence is really high, and the impact on their life is significant in many different aspects. And despite effective interventions on how to treat youth with depression, anxiety, or other mental health problems, we haven't been able, in a scale, to prevent those problems, to promote mental health, to change the scenery on the youth mental health crisis. And there is a group of papers, not only these two, there are other papers as well, talking about ways on how we should tackle this. And in a summarized way, it is about implementing large-scale versions of effective individualized programs. And they summarize this as a IS intervention setting. So the individual interventions, effective evidence-based interventions, is scaled at community level using implementation resources. This is extremely complex, of course. They also commented on some other points that it needs to be policy-driven, innovative. We should try to find innovative ways to deliver those programs at scale, and also try to reach community level all the way to the level of the policy level. And IMPROVA, actually, in our concept of the project, we were already touching a lot of those aspects that have been treated. Those are fairly recent publications. The one on the right summarizes those concepts, and it's from 2024. So what it is IMPROVA? In a nutshell, IMPROVA, it's a program that tries to promote mental health and well-being among adolescents, trying to reach different key players and settings around the adolescent. The school, the professionals in the school, so school staff, teachers, also the adolescents with contents for adolescents, and also for the families. And it's based on social and emotional learning interventions, which so far is the most effective for universal interventions for adolescents to promote mental health and well-being. It also integrates principles of cognitive behavior techniques, trying to reach those adolescents with subclinical symptoms, because CBT are the most effective technique for this population, and also focus on skill competence trainings instead of addressing only mental health problems. Actually, one of the papers that really addresses this comprehensively is one paper from Pim in evidence-based mental health. So what it is, the IMPROVA program? The IMPROVA program, it's a comprehensive program delivered online. And then we created the IMPROVA platform that we can summarize in 2 concepts: the intervention platform and the information platform. They are complementary. The intervention platform, they have dedicated modules, 20, 30 minutes modules, short modules, interactive modules, login protected for teachers and adolescents. And we also have the information platform, which serves as a standalone space to complement the contents and the information presented in the intervention platform with information for students, for teachers, and also for families. And this space is not login protected to be more easily accessible for them. And apart from that, we also have resources dedicated in the community. In our case, in the 4 countries that we developed together the program and that we are testing currently. I'll talking about this a little bit later with public health services. So any person inside IMPROVA can find the services around the mental health services in each country specific to their community. So I'm talking a little bit about the contents now. Adolescents in the intervention platform, they can find around 20 different modules in different topics that we can subdivide in 5 different domains. So about emotions, relationships, physical activity, sleep, and many other aspects. Teachers, we can subdivide in 3 different pillars about their own health, about health topics for adolescents, and pedagogical contents that they can use. And one thing that we would like to highlight here is that the IMPROVA program, it's completely flexible. We do not have a structured way that teachers or students in the first week, they need to follow certain modules. In the first month, they need to. This is actually our concept. It's a self-administered tool because each adolescent needs something different in different moments of the school year in their development throughout secondary education, because this program is directed to secondary educations in those 4 countries, in France, Germany, Spain, and Romania. So teachers, they can decide when to implement the contents in IMPROVA. IMPROVA, you can see also as a toolbox for them. And one of the contents that we have in the program, we also prepared 8 tutoring sessions. So teachers in all of the countries, they name it differently, but in all of those countries and in the European countries, teachers, they have a moment with a classroom that they can deal about any other topic that's not in the curriculum. So we prepared 8 tutoring sessions with complete guidance on how teachers can guide interactive talk with adolescents about the contents of mental health and well-being, and also making a bridge between the teacher's content and the adolescent content that they can find. The families, they can find in the information platform many information about positive relationships with the adolescents, on how to integrate family, school into the system in the promotion, prevention, and care of adolescents, positive behavior, emotional skills, communication, and many others. And all of this content was co-created with an extensive co-creation process. I would like to highlight just one piece of it, because the consortium, the entire consortium worked on this, but I would like to highlight one specific aspect. We included in the co-creation process the students themselves, teachers, and families, conducting more extensively focus group sessions with each one of these stakeholder groups. In total, we have around 100 stakeholders. If we sum all of the stakeholders groups, we conducted focus group sessions in all of the 4 countries to understand many aspects, and among them, the acceptability of the program, the appropriateness, and the feasibility of the program, and in addition to the barriers and facilitators of implementation. So the entire content was in many different ways co-created to the best of our abilities and considering the timeline with those stakeholders. And when the program was fairly finalized, we kind of created a users local group that we gave access to these stakeholders, to especially teachers and adolescents, to test the program and provide additional feedback about kind of the final product of the IMPROVA platform, the intervention and the information platform. And why IMPROVA is a unique program. So first of all, it's based on evidence-based programs, effective programs. Second, it's scalable and self-administered. Since we are implementing this online, using an online tool and online access it's fairly universal in Europe, in those countries especially. Users they can access at any time from anywhere. We included persuasive design. They are flexible structured program. For instance, in our program, we have a key structure of the program, but with a few adaptations. For example, in Romania, one of the modules was suppressed because of a feedback from the local teams that this topic wouldn't be well received by families, adolescents, and teachers. So we suppressed one of the modules for Romania, which is something that's reasonable because we need to be aligned with the reality of the place. We drafted very specific guidelines on how to do transcultural translation to take into account cultural aspects when we were translating the material initially drafted in English to the other countries and languages and had meetings about this. We also have an avatar, an animated avatar that you can see here, one of them. They'll be with me throughout my presentation to give me also some support. We were only able in this short time to design this program only because before two of our partners, they already had developed a comprehensive platform, the Sano platform, that IMPROVA is a layer on top of this platform. This is a research of over 10 years of two of our partners in the consortium. So that's why we were able to create all of this wonderful material that I'm presenting to you today, and having high security standards because this has been developed over a decade now. And we also included some gamification elements. I'm going to give you some examples of that. So as you can see in my previous slide, this is kind of the screenshot of the initial page adolescents have access, the list of the modules, and each module is working specific emotions. And once they complete the modules, they actually can follow the emotions that they have worked, the emotions that they did not work still so much, so they can go and develop any specific emotions further, like the social butterfly or knowing yourself, or strengths, body on mind, and so on and so forth. We do not have a lot of text. This was one of the feedbacks in the co-creation session. We included a lot of audios, visual elements, peer narratives that adolescents, because this is a very powerful psychological tool to use peer narratives to change behavior. And we also included other multimedia elements like videos, audios. It is also developing social emotional competencies on how to change the behaviors and giving choice and autonomy. They can choose where to start, which topics they are more interested, which type of elements or aspects they would like to develop further. And also promoting self-reflection, giving personalized feedback based on some small questions, and shaping the further content based on all of those questions. Providing extra exercises, PDFs that they can download and continue further. This goes not only for adolescents, but also for teachers. So now, I will present some results on the ACT we are currently implementing. From September last year, so this school year, we started implementing this program simultaneously in France, Germany, Romania, and Spain, with a structured program as flexible as necessary to the context of each country. So what I'm going to show here, it's not necessarily the implementation parameters, or I'm going to show you some of the baseline data of the questionnaires we had with adolescents and teachers, and some usage data of the program. Here we had around 20,000 eligible adolescents, some in all of the 4 countries. And you can see in the percentage of adolescents actually registered into the program, you can see some clear differences. And this is one of the interesting findings of IMPROVA. Those differences, why France had 85% registered and Germany has 19, for instance, to take the 2 extreme examples, it's because the age of consent. In France, the adolescents were able to give the consent for themselves by default. We did not need active consent for adolescents in France. They could withdraw their participation or provide this, what they call passive consent, whereas in Germany, all of the adolescents under the age of 18 needed to have the consent of the parents to participate. And in the other countries, in Romania, this cut point age is 16, and in Spain is 14. So you can clearly see on the percentages the impact of the ethical regulations on recruitment of the adolescents. And regarding the number of questionnaires, this also impacted as well, because the French team, they were able to be in the school to give support in the questionnaire assessment, whereas in the other countries, because of all of the work for getting the consents, the team was not able to be in the school for the questionnaire assessments, for instance. We had to rely more on the school staff to support us with that. Regarding some mental health status of adolescents, our primary outcome is overall mental health using the strengths and difficulties questionnaire. And we can see here that between 15 and 18% had some borderline symptoms of mental health problems, and actually around 20% of adolescents had some abnormal symptoms, which is fairly worrying. And if you look at the subscales, it seems like the emotional difficulties and peer difficulties were the subscales that they score the lowest. If we look at depressive symptoms, around 35% of adolescents had some important scores regarding depressive symptoms. Regarding anxiety, this number of moderate to severe symptoms of anxiety, it's around 25 to 30%. And if we look at school staff, surprisingly, around 22% of teachers or school staff sign up on average to participate in the program. But the ones who participated, most of them fill out the questionnaire that we gave to them. And there is an interesting number here, at least it's a surprise for me, that the vast majority of teachers participating in IMPROVA, they have more than 10 years of experience, which is surprising for me. I would expect actually that newer teachers, they would be interested in a tool like IMPROVA. And regarding the health status of school staff, we see that in France, apparently, the scoring and the reality in France is a little bit more worrying regarding perceived stress or burnout compared to the other countries. And now I would like to talk a little bit about the usage. We will be able, because the intervention platform, it's login protected, we were able to track the usage, the number of modules adolescents followed. So we have a detailed report, and we had weekly reports about that, and we did many different strategies to promote usage. So here, another impact of the ethical regulations is that the French team were able to support the login process of adolescents. Around 80% of adolescents in France made an account in the program, the ones eligible, the ones in the intervention group. Whereas in the other countries, this number varied between 25 to 45%. And regarding the total number of modules completed, in total, we had 1,400 modules completed by the adolescents. And for the adolescents who completed the module, on average, they completed 2.3 modules, meaning that for the adolescents who finished a module, usually they took another one. And looking at the percentage accounts who are doing modules, this number is a little bit different, which is interesting. For instance, if we consider we had also introductory module about the entire program and so on. So the usage here, it's around 35 to 50%. And you can see that throughout the school year, the numbers are not really go much higher. You have the beginning, it's really important on the usage, not necessarily. We succeeded in making them use the platform multiple times. And if we look at without the introductory module, the numbers of IMPROVA, they are around 20%, 20 to 40%, depending on the country. In this case, in Germany, since we had a lower number of participants because of the age, we imagine that in Germany, the ones signing in were the ones more engaged, more interested in the program. That's why we kind of explain this difference in usage here compared to the other countries, that the numbers are more comparable. Regarding school staff, a fairly good percentage of them registered into the program, but the numbers of percentage-wise of usage are lower than adolescents. So the number of teachers using without the introductory module, it fluctuates between 10 to 20%. Only in Germany that actually towards the middle to the end of the study, the usage increased significantly along the school year. And everything that I showed here is actually a result of this amazing consortium we have. So I would like to, I'm not finishing my presentation now, but I would like to thank expressively everybody who is here, who are not here, who are in the pictures or not. It's not possible to have everybody on the pictures because this work is only possible because of the consortium we have. I'm only the person here presenting this, but this is only possible because of each one of you. So thank you very much on that. So coming back to my starting point, did we succeed on reaching individual programs, effective programs at community level? Did we succeed? What I can say here is that not so much. The challenges for implementation, they are massive. The level of work and history you need to have with the system, meaning the schools, the teachers, all the way up to the policymakers in the municipality, in the region, or at national level. You need to build trust, and that takes a lot of time. A lot of our partners, we had previous collaborations with the school system, but that wasn't really enough. That in any of the countries, we had a gold standard implementation because the challenges, they are massive. Schools, they might be over interested in participating and implementing, but the challenges are massive there, and we needed more time prepping the groundwork before the implementation. We needed at least 1 year inside the school before actually implementing the program. And we have the limitations of any other research. We have a limited time, limited budget, but we needed to do the work. And But despite kind of this negative finish I'm giving, actually our numbers are not very negative. Pim, in his presentation, I haven't seen his presentation, but him and other specialists in the field knows that actually our numbers are quite good. Our numbers on usage, they are much higher than the average in non-obligatory programs. And there are many advantages on non-obligatory programs that we can discuss further later. So actually, I would like to finish with another picture of IMPROVA, because for me, IMPROVA is this huge toolbox that we can adapt. So we have a very good platform to implement a mental health and well-being program for adolescents, that it can be adapted to many different settings, because we have this modular structure that it's adaptable. It's naturally adaptable because the program, it's directed to the class because the teacher has the autonomy, the adolescent has the autonomy, but also we can adapt the program in many different ways. We have another project that's not in IMPROVA, but it's connected to IMPROVA, that can be another box implemented in this huge box of IMPROVA, for instance. So we have, in my perception, an excellent starting point to continue developing further, because we all know that a project at this size can't finalize the entire cycle perfectly in the first shot. So, and I would like to thank you for your attention, and I'm happy to take any questions that you or the online audience may have. Thank you so much. Catherine.
I think this works.
No, not for the online. Catherine, remember we are friends, huh? Make me an easy question.
I tried to. This was fabulous, and I'm always amazed when we see the full picture of everything that has been done since the first kickoff. I was just wondering, do you have information on access of the information platform? Like, because the teachers don't use necessarily the modules, but do they access the information platform or the other tools that you give them for the lessons? Do you know anything about the usage there?
We can track this information.
Okay.
I do not have the specific numbers for some reasons. One of them is that we cannot identify the person in the information platform because there is no login required.
Oh, okay.
And now during the implementation of the trial, we focused on the intervention platform to be able to direct strategies to support the usage on, because we could identify at the individual level, so we knew the usage per school, we knew the usage per country, so we were monitoring weekly to try to direct the strategies. But in the future analysis, we will know at least regional level, so we can indirectly identify the usage of the information platform. Because as you say, teachers, they had access to the intervention platform, but they may have used the information platform. But we kind of assume that the numbers of one would be kind of a representation of the other as well.
Okay. May I ask one more?
Yeah, of course.
Because the depression and anxiety were quite troublesome. Do you have information on gender or sex differences? No. Okay.
I don't.
Okay,
we do not.
that's fine.
We do have in our reports. If Julia knows this better than me, please correct me. But we did not see major differences, as far as I remember, across countries, and nothing more than usual regarding sex. So not big differences from the pictures we expected.
Okay, thank you.
Any questions? Yeah.
Thank you. I was wondering if there is any content or issue inside the platform? I know this is an individual level intervention, but about social issues and how this impact the well-being, for example, migration, gender violence, or something like that.
So this is a very important aspect. We treated that in the construction of the modules to treat all of those aspects indirectly. Instead of having modules specifically on migration, we decided that the entire program would address all of those points, or depression, or feeling sad, or anxiety indirectly. So it wasn't, and regarding any specific cases throughout the program, we had some incidental findings when we were doing the questionnaires and we had to react to them, but not related to the usage of the program necessarily on those topics to the best of our knowledge. Like, it did not get to us any information regarding this specifically.
Hello. Can you tell us a bit more about the implementation effort that you have done with the schools to incentivize the usage, the parents and the students, because probably that's the key aspect to have higher usage rates?
Of course. So we went to the schools in the beginning for school recruitment and enrollment, to students, to teachers, and to families. So this changed a little bit across countries because the reality is different and so on. But on average, in general, we would go to the school and go class by class to present the study. So we would go there, spend the entire day in the school, and go class by class to present the study to students. Then, kind of in the afternoon, we would go to the meeting of the teachers and present this to the teachers. In many of the countries we did this. And for instance, here in Spain, we also organized webinars in the evening for the families. So they could actually ask questions about the participation of the adolescents. So this was one strategy. And throughout the school year, after the enrollment phase finished, because we faced many challenges to have the number of schools, to have the number of participants. So I'm just summarizing here quite a lot. During the implementation phase of the program, we were monitoring the numbers and we were creating, for instance, blog posts. So in the information platform, we had a blog post about procrastination, for instance. And in this blog post, we were connecting with the modules in the information platform. This was directed to adolescents. We also created banners online, or they could also print to put in the boards in each class with these message boards that they could post in the website of the school. A link in the school website about the program. We also send via email to the adolescents and to the teachers, some also communication and dissemination material. So throughout the 5-6 months of pure implementation, we had at least one action per stakeholder on average per month, but usually more, different strategies. I do not know if we have time or if we have anything. One more question maybe? Over here.
Thank you so much for the presentation, Rodrigo. It's very interesting. I just have a question, I think related as well to my other colleague's question. In terms of within the platform, were there any adaptations or considerations that you made in the design of the actual platform to make it more attractive to adolescents so that they're more likely to use it and start and continue using the platform? Thank you.
You're welcome. One of them is actually the avatar that was following them throughout the, and as you could see, we have different versions of the avatar. connected to the stages in the module. So this is the celebration avatar. And then we have one more emotional that there is a heart inside of it. You can see that it's a little bit transparent, so this form can actually be shaped and so on. Another one was about thinking or reading. So the avatar was a major part, and it's also not a lot of text, very visual, a lot of figures and images, and as interactive as possible. Asking questions, giving personalized feedback. They could actually choose. For instance, one of the modules was to deal with the emotions. So we would ask which emotion they would like to work on that module. And then the entire module was shaped for the emotion that the adolescent chose. So actually it wasn't only 20 modules, because only this module, I think we have more than 15 emotions that they could work on. So we included many, many different aspects. They could also, in the radar graphic, see the emotions that they have worked, because each module was working 2 to 3 emotions. So if I finish 5 modules, in the end, I would have a map on the emotions that I worked, and in the emotions that I did not work so much, that I could take a look. So in many different aspects. Are we done? So thank you so much.
Thank you so much, Rodrigo. It has been so inspiring, and I'm very engaging to see all together. As you see, Rodrigo is at the heart of all this work and has led us amazingly, is leading us amazingly through this project. So now we will move on to our keynote speakers. I have the privilege, I'm truly honored to introduce you all, Professor Pim Cuijpers. Is Professor Emeritus of Clinical Psychology and Director of the WHO Collaborating Center for Research and Dissemination of Psychological Interventions at the Vrije University Amsterdam. And he's specialized in conducting randomized controlled trial and meta-analysis on prevention and psychological treatments of common mental health disorders across lifespan. He has published more than 1,300 peer-reviewed papers, chapters, reports, and professional publications, including 1,100 papers in international peer-reviewed scientific journals. Pim Cuijpers is editor-in-chief of the Journal of Consulting and Clinical Psychology, and recently received the 2024 American Psychological Association Award for distinguished professional contributions to applied research. He is inspiring and the best person we could have here with us today to guide us and to bring into on his keynote on, I'm trying to go there, prevention and treatment of depression in children and adolescents. Thank you so much for being here with us, Pim.
Thank you very much for the kind introduction and for being here. And for me, it's always a pleasure to talk about this subject because I think it's so important clinically. And that's also what I've done in my whole work before I retire, to try to improve mental health problems across the population. So I've not only worked with children and adolescents, but across the whole lifespan. And that's, that gives me the opportunity to look at this field also from a broader perspective. And that's what I will do. I will not talk about the IMPROVA project, but I'll try to look at it from a broader perspective, but I'll try to link to what Rodrigo just talked about. What I will do is I will first talk briefly about depression. Not too long, but I wanna stress a few things. I could have also talked about anxiety and stress, but we know most about depression. So that's why I think it's better to focus on depression. And then there are basically two things I want to talk about. Prevention. What can we do to prevent the onset of new depressive disorders? and then about treatment. And they are a bit different, but of course they're also linked. And I'll talk briefly about innovating treatments, because that's an important subject, because treatments work, but not that good. Yeah, very briefly, you know all this about depression, that it's very common, that a lot of people have it, that it's also very common in adolescents, etc., etc. If you want to know more about it, we wrote this Lancet paper from the Lancet Commission on Depression, where you can find anything you want to know about depression. I was mostly involved in the writing of the treatment part, but it has everything about epidemiology, etiology, anything you want to know. I do take one slide of it because I think that illustrates a few things which are important to understand what depression is. At the horizontal axis, you see the age groups. And at the vertical axis, you see the disease burden in terms of disability-adjusted life years, the DALYs. And so what you see here is a few things. One thing is that it's most of the disease burden is in low and middle income countries. So we are Europeans, and we talk about Europe, and these are all high income countries. But most of the disease burden is in low and middle income countries. If you simply look at the prevalence rates, there are more depressed people in China than the whole population of Spain. And there are more depressed adolescents in India than the whole population of Holland. So when you think about that, then I think it changes the perspective of what we're talking about. The other thing you see here, which I'm not going to talk about today, but it's a very important subject, is that it's mostly something about the working age. Most people with depression are adults in the working age. And that is also why depression is so expensive. It's mostly production losses. People don't go to work. People are not as productive at work. And if you look at these costs and you compare that to the investment in mental health care, then every dollar that you invest in mental health care, you have a return on investment of $3 to $5. So, and that's because of the production losses. The third thing, and that is important for today, is that if you look at the disease burden, it starts in adolescence. So if you talk about prevention, then it's, before the adult age that you have to do something. There are a few things you can do to reduce the disease burden of depression. So if you look at depression at the population level, you can either prevent the onset, so prevent people from getting depressed. You can increase the uptake because we know that a lot of people don't get treatment at all. I mean, in low and middle income countries, that's 80% of people with depression. There's hardly any evidence-based treatment at all. But also in high income countries, the number of people getting treatment is actually in all countries lower than 50%. And in specific target groups, that's much, much lower. So, and that's true, of course, for adolescents. Adolescents are notorious for not seeking help when they are depressed. But it's also true for older adults, for people from minorities, for people with low socioeconomic classes. So treatment actually is something for a very small group, elite, rich group of people in high-income countries. And if we want to change that, you have to change your thinking about what treatment is and how we can get that to the people who need it. Yeah, so reducing the disease burden of depression and other common mental disorders at the population level, that's exactly what I've spent my whole working life on. So on prevention, but also increase the uptake and develop better treatments. And so that's why I always like to talk about that. But let's go to the first part, prevention. And then we're really talking about preventing the onset of depressive disorders. So what can we do so that people who are not depressed now will not develop a depressive disorder in the next year? And Rodrigo, you already showed this paper. I think that's important because it also illustrates a shift in thinking in the psychological community. This is a paper which is the result of a meeting we had at the American Psychological Association, in which the association decided that they want to move away from the individual treatments to population health, looking at mental health problems from a population perspective. And so it's not just a paper describing possibilities. No, it's a change in the policies of the American Psychological Association. You probably know all this. This is when you talk about the prevention and treatment, I usually work with this scheme. And it basically says that if you meet criteria for a disorder, then it's treatment. If you do not meet these criteria, you talk about prevention. And there are 3 types of prevention: universal, aimed at the whole population, like the IMPROVA project. It's aimed at the whole population, regardless of the risk status, like school programs, mass media campaigns. Selective prevention is aimed at high-risk groups, children with depressed parents, children who had abuse, who had a traumatic event, etc. And indicated prevention is aimed at people who have some symptoms, but not a disorder, so subthreshold depression. So let's go all these 3 major types of prevention. Universal prevention, that's very attractive because the stigma is very low, and you give it to everybody. So when somebody is depressed and is sitting in the classroom, nobody notices that that person is depressed, and he still gets the intervention. So stigma is very low. It's also attractive because you reach everybody, and it's relatively cheap to go to schools and give some classes about depression. There are also main disadvantages. So one of the major problems is that it's very hard to show that it works in terms of preventing the onset of depressive disorders. So if you look at the general population, the incidence of depression is about 1.5% to 2%. Let's say 1.5%. That means that of the 100 people, random people in the community, 1.5 will develop a depressive disorder in the next year. If you want to reduce that to, let's say, 1%, then you have a reduction of 1/3 of the incidence. Then you will reduce that incidence from 1.5 person to 1 person out of 100. And if you think about a trial examining that, you can imagine that you need a huge sample size. In an early paper, I calculated that for eating disorders, and there I found that you need 3 million people to do a randomized trial to show that you have actually prevented the onset of eating disorders. And that's, of course, because eating disorders, the incidence is extremely low. And that's much higher in depression. But you easily talk about trials of 10,000 people if you want to show that it actually prevented the onset. And so that's a major problem when you look at that. And the other thing is that it's what we know from research is that universal prevention programs have small effects. And let's see what my next slide says about that. Yeah, I will talk about these small effects a little more in detail, but there's another problem. If you want to know more about that, you should read this paper. I think a lot of prevention programs are actually not really prevention. I've tried, I hope this illustrates it a little, because as we also saw from your presentation, Rodrigo, most students don't have problems. There is nothing wrong with them. They're not depressed or whatever. So if you give them an intervention, nothing changes. But when you look at most outcome studies, and many studies only report this, they report outcomes in terms of effect sizes. So they say, okay, we have a prevention program, and so when we look at the outcomes after the intervention, and we compare that to the control group, we have an effect size of 0.5 in favor of the intervention group. But if you actually think about what that means in terms of all these students, that means that the ones who didn't have anything, they didn't improve. There's nothing to improve because they have nothing. So if you find better outcomes of the whole program, that usually means that the ones who already had some symptoms were reduced. And that's good, of course, but it's not prevention. So it's actually a way of indirectly treating adolescents who already have symptoms. And it's not really prevention. It would be prevention if the control group got worse and the treatment group remained the same. But that's not what you usually find. So actually a lot of prevention programs are not preventing anything. They're indirectly treating people with existing symptoms. And then we got the problem of, if you want to know more about this, you should read this paper. So what we find in research on prevention programs for depression in adolescents in schools, then you usually find small effect sizes, let's say 0.2. A standardized mean difference of 0.2 between the treatment and the control group. That can mean two things. If this is a true effect, then the impact of such an intervention is huge. Because, treatments have an effect size of 0.8, but they only treat a very small sample of the total population. And if you have an effect of 0.2, very small, but with a huge population, the actual impact is much larger because the individual effects are smaller, but on a population level, the impact would be huge. The other possibility is if you have small effects, is that these are artifacts. That they are, when you find small effects, you really have to take care. Were the trials done well? Was everything done appropriately? And it's very well possible that there is no effect. So we actually don't know which of the two is true. It could be that we have a massive effect of universal interventions on a population level or no effect. And it's either one of the two. And we're not certain which of the two is true. And there have been a few trials now, one in Australia and one which I know better in the UK, in which they had a huge trial. The UK trial examined the effects of mindfulness in high schools. And so all students got mindfulness training in high schools. And there were, I think, 4,000 or 5,000 people in the experimental group and 4,000 or 5,000 people in the control group, and the effect was 0, no effect. And that could mean that universal prevention is not effective at all. And I think that is relevant for the IMPROVA project, because you use a different approach. Because all these trials, most of these trials, they simply give lessons in a classroom on depression, and that's it. But we know from other fields, from the health promotion fields, that it's much better to look at the community, where you look at the school community, where you look at where the directors of the school support the whole project, where you involve parents, where you involve teachers, where you make sure that the treatment system is in order and that students with mental health problems can go. And that has not been examined so extensively. So in that sense, I think the IMPROVA project is very interesting and important. So let's go, how am I doing in time? Okay. So let's go to selective prevention, which is aimed at high risk groups. There are lots of high risk groups in mental health, in children, adolescents, but also in adults and older adults. The most important high risk group is children of depressed parents. It has been estimated that 50% of children with a depressed parent develop a depressive disorder themselves before they're 21. All the other high-risk groups have much lower incidence rates. And there are also all kinds of interventions aimed at high-risk groups. In children and adolescents, for example, all these support groups for children with depressed parents. But in adults, you have also, all these interventions for people who have lost somebody by death. People who got retired, like me. I'm a high-risk person. And so when you look at the studies in these high-risk groups, usually they don't examine the incidence, the effects of the intervention on the incidence. What they usually do is, like in most school-based programs, they just look whether the level of depressive symptoms has been reduced. And when they find an effect size of 0.5, whatever, they say, see, our intervention is effective. But of course, it's the same problem as in universal prevention, that it's not really prevention. And when I think of selective preventive interventions, why would people participate in a preventive program if they don't feel any problems with a high-risk situation? So most people going to selective preventive programs already have symptoms. And probably only a very small proportion will not have mental health problems. But on the other hand, as I will show you, we do know that selective preventive interventions are effective. But I'm not certain whether it really it really gets to the people for whom prevention is relevant. Yeah, and another problem is that most at-risk people do not develop a depressive disorder. So we have a lot of high-risk groups, and most of that comes from epidemiology. And when you read papers about that, people say, yeah, we found a high-risk group with a relative risk of 4, and then, or an odds ratio or whatever. And then epidemiologists are really very happy because it's highly significant, important high-risk group. But if you think what it means, it's not very useful for a prevention researcher or a prevention specialist. So when we say, okay, in the normal population, you have an incidence rate of 1.5. So 1.5 person will develop a depressive disorder in the next year. If you have a relative risk of 4, that means that 4 times 1.5, which is 6%, will develop a depressive disorder, meaning that 94% of the people from that high risk group will not develop a depressive disorder. So, and even if you think about children of depressed parents with 50% incidence before the age of 21, when you think of that in terms of, let's say, the incidence starts rising at the age of 13, when the incidence rates of depression starts increasing. Then you have 8 years in which people develop the depressive disorder. And so that means that roughly 6% of people, of these children, will develop a depressive disorder per year, which still means that from a prevention point of view, it's not very useful because we know that only 6% of this target group will develop a depressive disorder in the coming year. So if we want to change that, we have to look at combinations of risk factors. We have to look at ultra-high risk groups, where we have a combination of high risk factors, where the incidence rates are, what we would need is incidence rates of 30, 40, 50%, because then you can really do prevention trials to reduce that risk. Okay, indicated prevention, which is aimed at people with symptoms, but not a depressive disorder. And there's pretty good evidence that it works. So usually these interventions are based on CBT or interpersonal psychotherapy, and they're light treatments, so to say. So simplified versions of treatments. And if you give them to people with subthreshold depression, you can reduce the incidence. People getting these interventions have a lower risk of developing a depressive disorder. I will show you a few data later on. You can also relatively easily identify these people through screening. So you can, for example, at schools, you could do that. There's a lot of research on that. You can go to in perinatal care. You can do screening. You can do screening at a GP office. So it's relatively easy to identify people with subthreshold depression. However, if you offer these interventions to people who could benefit from it, the actual uptake is extremely low. In the Netherlands, we had, until about 10 years ago, we had a system where everybody could get indicated prevention for free or for almost for free. And all these regional mental health institutes offered psychoeducational courses on mood management, which is actually a preventive intervention. It's a CBT-like treatment for subthreshold depression. And in one study, we looked at the total number of people participating in this. Over time, I calculated there were 100,000 people who participated, which in individual cases is extremely useful because maybe we have prevented a lot of depressive disorders for these individuals. But if you look at the population level, that's less than 1% of the people with subthreshold depression. So the actual uptake is extremely low, and we shouldn't expect that can reduce the disease burden of depression substantially. But we did a large meta-analysis of interventions to prevent the onset of depressive disorders. And it's only trials in which people had a diagnostic interview at baseline, and the people with a depressive disorder were excluded. So it were only people in which a diagnostic interview confirmed that they did not have a depressive disorder. And these trials had to do another diagnostic interview after 1 year or 6 months or whatever to look how many people developed a depressive disorder. So we really could examine the incidence of depressive disorders in these trials. Yeah, we had 50 trials. I will skip this. This is the result. So we had 50 trials in total. Most of them were indicated. It's a pretty large sample was selective prevention, and only one in universal prevention. But I explained why that's. I already explained why that's very complicated. And 14 were aimed at children and adolescents. 14 of these 50 trials. And yeah, what we found is an incidence rate ratio of 0.71, meaning that the children and adolescents who received the intervention had 29% lower chance of developing a depressive disorder than people in the control groups. So it substantially reduces the incidence. And that was also found for indicated prevention and selective prevention. Here you see the results specifically for children and adolescents. The results are not significant anymore, but that's probably because of low statistical power. You can also, another way of looking at indicated prevention is that you have a group of people with relevant symptoms. So they're not depressed, meeting all the criteria, but they do have symptoms. So we did one meta-analysis in which we looked at it from that perspective and examined whether you can treat subthreshold depression in that way. And that was, we found pretty good outcomes with that, an effect size of 0.38. I will come back to that later. So where are we in the prevention field? Where are we? Well, if you look at it, we're not yet certain whether universal prevention works. We haven't tried everything, but we're not certain whether it works. So selective prevention is promising, but it probably only reaches a very small fraction of people without already existing problems. And that's complicated because we don't really have we don't really know much about risk factors which are useful for preventive interventions. Indicated prevention works, but the uptake is too low to make an impact on the population level. So what should we do next? Well, one thing, it's not very clear, but there has been a report from the Alliance of Mental Health Research Funders in 2020. And what you see there is that of the total amount of money spent on biomedical research, only 7% goes to mental health research, while the disease burden is twice as large. So it's not evenly distributed according to the disease burden. And that's 7% spent on mental health research. If you look at research aimed at prevention of mental health problems, that is 7% of that 7%. So that's less than 0.5% of all the money spent on biomedical research goes to prevention research in mental health. And I'm absolutely sure that a lot of that prevention money is actually not about prevention, but it's about treatment researchers who are clever in formulating their research as if it is prevention. That's actually one of the reasons why in the 1990s they developed that scheme where they separated prevention from treatment. I talked with a few people in that committee, and they confirmed that you can everything is prevention. If you, I mean, the psychotherapy, you can say, well, psychotherapy is aimed at preventing people going to an institute, or it's suicide prevention, or it's relapse prevention. So it's a lot of research on prevention. It's not preventing the onset of new disorders, but it's another way of treatment. Yeah, so of course, what I always see now, especially since COVID, is that everybody talks about how important mental health problems are for young people, but also for the broader community. And if politicians say that, I think they should take the consequences of that and invest money in developing it. And the IMPROVA project is a good start. But it's not by far enough if we really want to make an impact. And so I talked about these, that we need 10,000 people in trials in universal prevention, but that is done in other fields. So why don't we do that in mental health problems if it's so important for politicians? Then I think we should move to more community-based interventions. And I think in the IMPROVA project, you are doing a very good job in that sense. That it's not just single interventions, but that it's embedded in the community. And we know from the substance use field and the health education field that these are the most effective interventions, community interventions, like the community of schools, like universities, but also the working place. Yeah. I can talk a lot more about this, but I won't do that. Yeah, one thing I want to show, and I think in the IMPROVA project you already do that a little. I was fascinated a couple of years ago when I read a study in older adults, where older adults with insomnia were included in a randomized trial. And they excluded the people who had a depressive disorder. So it's really a prevention trial. And so they treated the insomnia in older adults and then looked after a year at the incidence of depressive disorder. And it was very clear that the treatment of insomnia reduced the incidence of depression. So you can treat insomnia and at the same time reduce the incidence of depression. And I think that's a fascinating idea. And we are working on that in, I'm not anymore, but when I was still working, we had this very large project in college students. And we talked with college students what their problems were, what they experienced as problems. And they said mood problems were important, but number one was procrastination. And number two was perfectionism. And so you can, and we've developed all these digital tools for these kinds of problems. And what we see is that a lot of students who participate in these programs are actually also depressed. And if you give them that intervention, you see that a lot of them, that the effects on depression in those who are depressed at baseline are very comparable to the ones who participate in the depression program. So you can also indirectly treat and prevent mental health problems in any population. Okay, how much time do I have left? 20 minutes, okay, I will quickly. Yeah, so treatment. So we're doing all these very large meta-analysis. If you want to know more about this, you should go to this website. We also have a few data sets on children and adolescents. You can run your own meta-analysis here. You don't need any software, any syntax or whatever. You can select subsets of data, meta-analytic data sets, and run a full meta-analysis online, including, so if you want to know whether IPT works in adolescents with depression, you can go here and run a meta-analysis. It's done in a minute. But anyway, so we have a lot of data on psychotherapy for depression. More than 1,000 randomized trials now. 80 in children and adolescents, but also in, comparing therapies with each other, with control groups, with pharmacotherapy, combined treatment, digital versus individual, group versus individual, et cetera, et cetera. So we know a lot about treatment of depression. If you wanna, we have done more. I've been working on this since 2007. And so we're updating this every 4 months, this data set. And over that time, we have published more than 100 meta-analyses. And if you want to know more about that, just get an overview of all the effect sizes in groups, and comparisons, and age groups, you should read this paper. But I also want to highlight a paper that was published in April in the American Psychologist, in which we not only looked at the effect sizes of psychotherapies compared to control conditions in all age groups, but we looked at the effect sizes, but also examined historical trends in all these trials. So we had 560 trials, something like that. So a huge sample. And this is the historical analysis of specific target groups. And this line is research on psychotherapy in adults in general. And this is in adults with general medical disorders. And this orange line is on children and adolescents. What this says is that research compared with research in children and adolescents compared with research in adults is significantly reduced. So there's much more research in adults, and that's increasing. And compared to that, research in children and adolescents is significantly lagging behind. And that's important because, as I will show you, the effects in children and adolescents are much smaller than in adults. Same is true for type of therapy. So CBT is becoming more and more dominant over time, while there's no evidence whatsoever that CBT is more effective than IPT, psychodynamic therapy, problem-solving therapy, behavioral activation, but it is becoming more and more dominant. So we did one large network meta-analysis in adults, and in a network meta-analysis you can compare different treatments at once in one big analysis. So we included all trials comparing therapies with each other and therapies with control conditions. And that means that you can use all the direct evidence, but also all the indirect evidence. And so you have all the evidence that is available, you have that together in one big, huge analysis. And so we had 8 types of therapy. I have no time to go into that. We had 8 major types of therapy, which are at least examined in 10 randomized trials. And yeah, what we found basically is that there is no significant difference between therapies. And this is in adults. I will come to children, adolescents in a minute. But it shows that all major therapies work, and there's no significant differences between therapies, except maybe for non-directive counseling. But that's also often used as a control condition. And in another study, we have shown that if it's not explicitly used as a control condition, the effects are also comparable. So how is that in children, adolescents? Well, unfortunately, there's much less research. What you basically, can you read this? Yeah. Yeah, what you basically find is that IPT and CBT are the only ones that are effective. That's probably because the number of trials is much smaller than in adults. But it is the reality that actually we only have 2 therapies which are effective in children and adolescents, and that's IPT and CBT. And we have looked at that. We have also looked in one big meta-analysis on psychotherapies across all age groups. So from children, adolescents, young adults, middle-aged adults, older adults. We even had a sample of 10 studies in people older than 75. So older, old people. Yeah, and this is what we found. There is no significant differences between age groups when people are adults. So regardless of the age groups, therapy always works. But the effects are significantly smaller in children and also in adolescents. However, one problem of this research, it's always presented in terms of effect sizes. And effect size means that the treatment and the control group differ 0.5 standard deviations from each other. So then the effect size is 0.5. How are you going to explain that to a patient or to a clinician who is not, who doesn't know much about statistics or methods or whatever? So what does it mean? What does it mean? So you have these normal distributions and then these control group and treatment group, they differ from it. What does it mean? And so what we did in a few studies is that we looked at response rates, absolute response rates. So we defined response as a 50% symptom reduction from baseline to post-test. And we looked at all the other things, but because of time, I will skip that. So if you look at the response rates, that's 39 for treatment. So the proportion of people getting CBT is 39. So 39% of people getting CBT respond, meaning that 60% do not respond. And in the control groups, that's 28% for care as usual and waitlist 20%. It's significant, it's important, but it doesn't mean that everybody gets better when you get treatment. And I know that a lot of clinicians think that if you use an evidence-based treatment, it should work because it's evidence-based. And if a patient doesn't get better, then it's maybe I didn't do the therapy well. Maybe we should do the diagnostics all over again. because it doesn't work and it's evidence-based. So something must be wrong. But that's not the case. Evidence-based doesn't mean that everybody gets better. And treatments work, but they're not that good. And so, I will skip this because of time. We have done that also in adults. And what you see there is that the response rates for depression are very comparable in adults when they get treatment. It's 42%, while it's 39% in children, adolescents, so very comparable. What the difference is that the response rates in the control groups are much higher in children and adolescents than in adults. In adults, it's 16, 17%, while in children and adolescents, it's 20, 28%. And so treatments have the same outcomes in children and adolescents, only the control groups are different in children and adolescents compared to adults. And that's the reason why the effect sizes are much smaller, because effect sizes cannot look at it like that. What's important for today? Do I have time for that? Yeah. What's important for today also is we have examined a lot of things, but one thing is that we also looked at how can we deliver interventions? Can we do that digitally? Does that differ from face-to-face formats? And we have done this in adults. There is not enough research in children and adolescents to do something comparable. So but I don't think there's any reason to assume that this is different in adolescents. But so what we included all the studies, only CBT, because that's the majority of studies. It could be done individually, in groups, by telephone, guided self-help, which is usually digitally, but it can, in some cases, also be done by a book and telephone support. That was done before the internet. And unguided self-help, which is almost always done digitally. So then you go to a website and you get CBT on that website with no support whatsoever. And so what we could compare all these formats with each other. And what we found is that as long as there's human support, there's no significant difference between formats. So you can deliver CBT individually, by telephone, in groups, digitally, and there's no indication that the effects are smaller. It is smaller in unguided interventions. So if there's no human support, the effects are still significant, but much smaller than with than person-supported interventions. Yeah, there's a lot more I could talk about, but because of time, I will skip this. If you have questions about this, we have examined everything on specific target groups and age groups, and how many sessions do you need, about the frequency, in low and middle income countries, etc. Yeah, will I do this? Well, this very briefly, we did one, what we call individual patient data network meta-analysis on digital interventions for depression. That is led by my colleague Irini Kariotaki, who collects all the primary data from all these trials on digital interventions for depression. And in this meta-analysis, we looked at guided interventions, unguided interventions, and control conditions. And because we had the individual patient data, meaning that we could examine who benefits from guided and who benefits from unguided. Yeah, and very briefly, this is a screenshot, so I cannot do it here. But you can fill in all the personal characteristics on this side. So the PHQ-9 level of depression, age, gender, relationship status. These are all the relevant predictors of outcome. And so you can fill that in for a specific patient. And here you see the outcomes, what guided does, what unguided does, compared to control conditions. In general, we found that guided and unguided are better than control conditions. And there's no difference in mild depression, but there is a difference in more severe depression, where guided interventions are more effective. But it can be different depending on the personal characteristics. And I think this is an important step to personalized treatments. Yeah, one important thing is, of course, that much of the research, I've shown you all these meta-analysis, but there are all kinds of methodological problems. I mean, we know that waitlists overestimate the effect sizes. There's a lot of risk of bias, so to say, the weak spots of randomized trials where they have not been done very strictly. We know that there is a lot of publication bias, negative studies that are not published. We know that researchers tend to select the best outcomes and publish about that, and the outcomes which are not so good, we leave them out. So that inflates the effect size, and we can examine all these methodological problems pretty well. And if you look at the effect size, if you adjust for these problems, then the effect sizes are half of what you would expect if you don't adjust for it. So that's something you always have to keep in mind when you look at research like this. Okay, innovations. There's a lot going on. So I just got a paper accepted in World Psychiatry in which we looked at all the innovations, and it's too much to go through them all. We differentiated 4 major groups of innovations. One is in the digital field, including serious games, like you also have included apps, ecological momentary interventions, just-in-time interventions, but also avatar therapy for psychotic patients. Of course, now with ChatGPT, you have a lot of trials coming up. There's not much yet, but there are trials coming up in which people talk with large language models, so to say. It'll talk with ChatGPT. And as a therapist, there was one trial in the New England Journal of Medicine, which had good effects, but not better than unguided interventions we already knew. So I'm not sure whether it will actually increase the uptake. I always think about interventions. In adults, we have, okay, let's take adolescents. You have 39 response rate of 39%. We're not gonna increase that with another 39% with an innovation. So if we're gonna improve that, it will be with small incremental steps. If we have an innovation where you have a community intervention in schools, where you have where you can increase that response rate from 39% to 45%, that will be a major improvement. And that's how all these innovations, there are more than 35 in the paper that we discuss. All these innovations have the potential to improve outcomes, but none of them will be a silver bullet. There are no silver bullets in our field. That's impossible. We wrote a paper about this published last week or 2 weeks ago in the British Journal, where we try to assess the strength of innovations. And I won't go into the details, but it's based on this assumption that 42% of people with depression respond. And while in placebo, that's 31%. So if we want to have a treatment that is twice as good as the difference between treatment and placebo, then you still get to, 54%, and it's not a silver bullet. And then it's a treatment which is twice as effective. And it's not going to happen. And so if we want to improve treatments, we have to do that with small incremental steps. And there's a lot of research in trying to realize these small incremental steps. But we have to keep in mind that in the past 50 years, the treatment effects have remained a flat line. We've published about that. No improvement at all over time. 50 years of research and a flat line. So it's good that we try to improve it, but I still have to see each of these innovations, whether they can actually make a difference. Okay, I still think that the prevention field is stuck in a way, because universal interventions, we don't know. Selective and indicated preventions may make a difference, but the uptake is too low. So we have to think about that in a different way. We need definitely more money for research, and we should stop. In many ways, I wrote about that. In many ways, we have done the easy things in the past 50 years. The easy trials in which we need small sample sizes, which can be done relatively easy. But if we want to really go ahead, we need large trials, 4,000 people, 5,000 people. And there are a few trials now which are so big, also in the digital field. But we need more of that kind of research. And what I also think is that treatments work. It's better to get treatment than to get no treatment, but that doesn't mean that everybody gets better. And we have to think about, what do we do with the people who do not respond? Do we start with CBT and then IPT, or do we start with IPT and maybe we should start with behavioral activation, and if people don't respond, expand that to CBT? Maybe at some point we should add drugs. That kind of research is not done, and we really need it. And yeah, I hope there will be innovations. Of the more than 30 innovations that are currently being examined, I hope there are a few that will actually make a difference, but they will not be silver bullets. And that it will all be incremental small steps to improve outcomes. Thank you for your attention.
Okay, any other questions, comments? We can start with those online.
So we have Sandra here, who asks, thank you, Professor, for your brilliant talk. Based on what you've shared about the different approaches to prevention, what lessons do you think could be applied to the role of schools and communities in supporting young people experiencing depressive symptoms?
Sandra was the one asking it, right? Yeah, Sandra, you can probably say, I talk to you there in the camera. Yeah, it's a very good question. And I think, as I said at the end, we should not expect silver bullets. So if we can improve things, then we have to do that in small steps. And actually, I think the IMPROVA project is one of these steps. You have to invest a lot of resources in getting something going. But the real work, the real potential for improvement comes after that. Because if you want to change things for adolescents, as I said, you have to work in the community. It's not a one-time thing where you go to schools and explain about depression and how you can change your thinking or about relationships. No, that's not what adolescents are busy with. They are busy with completely different things. And so you have to keep on, you have to change the environment so that when something happens, that the adolescents are capable of handling it, but also that the environment is capable of handling the problems that rise. In terms of that the parents know about it, that they know that they, that if their kid is depressed, they cannot solve it. They are the parents, not a professional. They have to know about depression. They have to understand that it interferes with the communication with the adolescent, where they try to help and the adolescent just wants nothing. And they get angry because they've tried this and tried that and he still doesn't want anything. But it's also the schools, that the directors support this, that it's not something of a few individual teachers who are enthusiastic about it, who are willing to change something. No, it should be the school supporting the system. It should be about the teachers, that they can recognize the systems. It's about having the classrooms, the universal prevention in the classroom, but also selective prevention. Do something for specific target groups, and you have to have a good professional support system, psychologists or coaches who are there, who can talk with students who have problems, and when needed, refer them to the mental health system. So I really think this community approach can make a difference, but we have to show it. And if you want to do a randomized trial examining that and compare schools who get such a system with schools who don't do that, you have to randomize schools. And you need, 10 schools in one group and 10 schools in the control group. And maybe a third condition where they only get classroom lessons. And that's a huge trial. And that's very complicated. Yeah. Is that an answer?
Yeah, I still remember your talk 20 years ago, so this one is going to have a major impact too.
Now you make me feel so old.
Yeah, me too. So, you said, okay, we mostly did the easy work.
Yeah.
And I think your graph with the adult interventions is also a bit a reflection of this, because it's much easier to do research on adults.
Yeah.
And have their consent. And I think
Yes.
Rodrigo's numbers also reflected the problem that we have with active parental consent, which was increased through the introduction of the GDPR.
Yeah.
So I was wondering, do you have any advice, like how can we motivate or convince policymakers or ethical committees to abandon active parental consent and do the default passive parental consent, so everybody participates except if parents were to say you may not?
Yeah, that's a very good question, but also a very difficult one, because it is also important. I mean, in Holland, you know about that. The general rule is that you should not do research with children and adolescents because they're vulnerable. And only when it's really absolutely necessary, you should do research at all with children and adolescents. And that's also for a good reason, because they are vulnerable. So in a way, I understand this. but it also limits doing good research. Yeah, I've had problems with that in my own research also when we try to do trials in adolescents. That's almost impossible. Yeah, I mean, it would already be solved. I mean, I don't know how it's in Spain, but in Holland, if you need parental informed consent and you need the consent of both parents, then it's impossible for children of parents who are divorced. You will never get that. So that means that you cannot do research in that. And that would already be a partial solution if you could get parental consent from one parent. Yeah, I'm afraid I don't have a solution for this. I think it should be something like that you on a national level try to develop a research agenda and discuss that with national ethical committees. So, and then you try to, but that requires, I mean, that's a project in itself to get that done. And then also to get that done in multiple countries. But as I said, I mean, in the cancer field, in the heart disease field, there are trials with, you know, multi-million projects across I don't know how many participants. And why doesn't that happen for depression in adolescents? And I think maybe we should also stop doing these easy things, because then you get a whole research field doing easy things, and politicians can say, okay, see, there's a lot of happening. But it's suboptimal research that we're doing. And if we would all say, no, we're not going to do that until you fund good research, high enough power that we can work out things like this, then maybe that's better. Yeah, I don't know.
So, actually I have two questions. I'll start with one. Taking your experience, you've talked, when I was working, now I'm retired, and so on. If you're starting the field now, what would you do? What recommendation would you give?
Oh, that's an easy one. How much time do we have? Yeah, that's a good question. I think that's impossible for me to answer, because I don't think I would do things differently. I mean, I only worked at the university for 20 years before I retired. Before that, I worked in mental health care. And I was happy there too. And I think I developed all kinds of manuals and interventions, and I like that a lot too. So I think I try to adapt to but the thing that I focus my research on is what can we do at the population level to reduce the disease burden, so that we try to step away from the individual, but try to look at it from a broader perspective. What can we do then? And that gives a completely different idea of mental health care. And I think I like that a lot. And I think I would focus on that research question again if I had to start all over again. I wouldn't do all the projects anymore with the money and the bureaucracies and no, that's
It's your answer is good because it's connected to my second question. So let's say that the preventive interventions in youth, they have small effect sizes, because we are looking at short-term effect. Do we have good estimations on these small effect sizes, but their impact, long-term impact? Because if they're really preventing something in a small scale, you said in part of your presentation, but not necessarily how big this would be, because this could be also a good leverage to go to the policy or to get more money? Or
Well, we don't know what the long-term effects are. I mean, all these trials are already expensive because they have to do the diagnostic interviews. The number of people you have to include in these trials is much larger than in a treatment trial. So they are large, expensive trials with diagnostic interviews at baseline and post-test. So doing these trials and getting short-term outcomes up to 2 years where we find positive effects, that is already a major thing. But if we want to, I really think that if we would do prevention trials starting at birth or before birth and focusing on high-risk groups in the first 1,000 days, and look at attachments, look at abuse and neglect in that period, and we would be able to follow these kids over time. I mean, could be, I didn't talk about it, but that's one of the options that in my papers I talked about. And that's what I would focus on. Yeah. Yeah. Yeah.
Thank you for your very inspiring talk. For me, it was a privilege to attend to this session. I was wondering, there's a big discussion in the literature about moving to transdiagnostic approach because many of the symptoms of common problems overlap, like for depression, different kinds of anxiety, and so on. And I was wondering, what's your take on this? Do you think it will help us in getting more fine-tuned selective interventions, or does it bring more noise into the research? Is it feasible to move to this sort of an approach from your perspective and from a research standpoint?
Yeah, I mean, transdiagnostic interventions are they're one of the innovations, definitely. And we included that in our World Psychiatry paper, which is in press now. Yeah, I think it has a few advantages. So it's easier to diagnose. You can do that more simply because it doesn't really matter whether it's a depression or anxiety or whatever. It's easier for the training. Because you can train people to deliver transdiagnostic interventions and you do not have to do all these different things. A disadvantage is that that many of these interventions are actually aimed at depression or generalized anxiety, and it's not focused on phobias or on panic, which I think could use a specific approach. And there's no evidence that it's better than disorder-focused treatments. And so, yeah, I think it could be an improvement, but I'm more interested in improvements that really get better outcomes. And I haven't seen that for transdiagnostic interventions. Yeah.
Any last question? We have time for one more.
Hi, Professor. Thank you for your talk.
Maybe like this? Yeah. Thank you for your inspiring talk. I was wondering, because you were talking about the whole system surrounding pupils especially, do you see a role for media and especially social media with it growing in that system as well?
Yeah, that's a very good question. I try to stay away from that discussion because the people saying that it's not good for your mental health or it's neutral, there are sometimes physical fights, right? So I try to stay away from that. I think social media can certainly play a role in this, in the sense that it is a way of connecting, and it's a way of getting messages to the people who need it. But of course, you have to take care of the dangers and all the that you get into these flows which narrow your view. And yeah, and in Holland they're now talking about prohibiting smartphones before 14 years. And I think it's certainly something to consider. Yeah. But as long as they're there, I think you should use them where you can. That's with all these community approaches. It's not that you choose, okay, we're going to do this for parents and that for, no, you have to go to the community, talk with people, have a steering committee of people involved and trying to coordinate it. And they come up with all kinds of other things. And you have to be open for that. And that's also a key issue of community interventions, that it's not fixed and it's not programmed. It's something that people own, that people do themselves. That's they are the coordinating part of it. Yeah.
Okay, thank you so much, Pim. I think with that last reflection, I hope you all own something of all this amazing contribution that we have had. It has been such a privilege. Thank you so much, IMPROVA team, Pim, for being with us, and to you all for coming and joining us. Please stay. There is a coffee in the just outside, and have a time to talk, to continue the conversation, because the topic is worth it, and we will continue. Thank you very much.